This lecture is going to be about mycobacteriology. It's just the very basics, primarily meant for board review or a brief review of this very important topic in microbiology. First thing we're going to talk about is the PPD, or the purified protein derivative. We've also known this for many, many years as the TB skin test. For decades, we used this to determine exposure to Mycobacterium tuberculosis. We called it the MAN2 test. We used 5 tuberculin units with an intradermal injection. As part of the problem with this test is sometimes the intradermal injections were not truly intradermal, and that can make this test be thrown off a bit. The purpose of the PPD, it detects past or current TB exposure, and it does cross-react with the BCG immunization. Over time, many publications have shown that it's not a very sensitive test, and it can have up to 25% false negative reaction. The PPD measures delayed hypersensitivity response to TB-related antigens, and as I said, this includes the antigens of BCG. T cells react to these TB-related antigens, a lymphokine is released, and it forms induration at the injection site. So that's what you read as a positive PPD, is the actual measurement of induration, not just the redness. The induration is actually measured in millimeters after 48 hours of past injection, and if it's greater than 15 millimeters, it is either a positive reaction or you need to check the patient's history for BCG immunization. If it's greater than 10 millimeters in an immune suppressed person or a person that has just been exposed during an outbreak situation, that is also considered as positive. It's been interesting. This test has been used for many decades, but there's been some recent shortages of the Tubersol, or so-called PPD reagent, and this has led us to a change in many people using what's called the interferon gamma release assays. On the next slide, you see that it's the cell, we're going to talk about the cell mitogen assays for TB screening, or the so-called interferon gamma release assays. The two most common are the quantiferon TB gold, or QFT, and the T-spot. These are done on whole blood, so a blood draw is required, and these tests screen for cell-mediated immunity to TB. It's able to detect both latent TB and active infection, but it is not supposed to replace culture or other diagnostic tests to test for someone that has active tuberculosis. One of the really good things about these cell mitogen assays is they're independent of BCG exposure. They're far more specific for the TB complex organisms than is the PPD. However, there is a few cross reactions with a few very uncommon mycobacteria. It's useful for screening the BCG immunized population where the PPD cannot be used due to false positive tests. It's meant to replace and improve upon the PPD skin test. The whole blood has sensitized T cells to TB, of course, and in the normal immune population, it can be stimulated by antigen peptides that are specific to TB, such as the ESAT6 and CFP10. Then it secretes cytokine interferon gamma. The amount of interferon gamma secreted is detected by the EIA assay. On the next slide, we're going to start talking about the general features of the mycobacteria, or the so-called acid-fast bacilli. These are closely related to the genera Nocardia, Corynebacterium, and Rhodococcus. What does the term acid-fast bacilli refer to? It means that once the rot is stained, it resists decolorization with acid alcohol. And the acid alcohol generally used in the acid-fast stain is HCl. It's on gram stain, the organism is very beaded and faded, and a gram stain is not considered a good stain to detect AFB. Also, it's important to note to differentiate AFB staining of the mycobacteria from the partial acid-fast stain used in Nocardia-like species. The AFB stains used with the AFB are HCl to decolorize organisms. This is a very harsh decolorization and is meant for true AFB. The partial acid-fast stains, or PAFs, are acid-fast stains that use H2SO4 to decolorize. This is a more gentle process, and it is perfect for Nocardia, which are considered to be partially acid-fast positive, but truly AFB negative. Other general characteristics, which are shown on the next slide, show that mycobacteria are aerobic, they have no spores, slightly curved or straight rods, they rarely branch, they're variable in length depending upon the species. They can be very hardy in the environment for months, and most grow on simple substrates. Mycobacteria include obligate pathogens, opportunists, and saprophytic species. There's a high amount of mycolic acids and free lipids in the cell wall, which give many properties to this genus, including the acid-fast staining properties. On the next slide, we'll talk about the identification of the mycobacteria. For decades, the identification was based on the production of pigment in the light and dark and biochemical reactions. With expanding taxonomy, biochemical reactions are not really able to separate and identify some of the newly recognized species. So we've moved on to some new methods for identification. For a while, high-performance liquid chromatography, or HPLC, was used to help identify the mycolic acids. This method has been used for a long time, but good but not the best for definitive speciation. We've also evolved into using genetic probes, which include RNA, DNA hybridization probes, MALDI-TOF, which is mass spectrometry to analyze proteins. And also, due to the complexity of taxonomy, many people are using sequencing, using 16S RNA for genetic sequence identification. So you can see that the taxonomy and the basing your identification on biochemical reactions has really gone through some very, very major evolutions. And really, as I said, biochemicals are really not that used anymore. But that does not mean that the history in using and learning about these identification methods are not of worth. So we're going to spend a few minutes talking about Mycobacterium taxonomy and how some of the biochemical reactions have been used in the past for the identification of mycobacteria. On the next slide, we're going to talk about the Mycobacteria taxonomy. TB and genetically related organisms that are separated taxonomically from other species. So the TB organisms actually include Mycobacterium tuberculosis, M. bovis, M. africanum, and some other very rare species. These are the group of organisms, as I said, that are referred to as the TB complex. Other mycobacteria in the TB complex are grouped into what are referred to as MOT. MOT are mycobacteria other than TB. One of the primary taxonomic systems that we used for many decades was called the Runyon system. The Runyon system is used to classify those species that are not in the TB complex into 4 groups. So the Runyon system classifies the MOT. The Runyon system is a very basic classification system based on what happens to the mycobacteria when they're exposed to the light or when they're in the dark. Pigment when exposed to light in the light test, pigment in both light and dark in the light test, no pigment produced whether they're light or dark in this light test, and the growth rate. On the next slide, we're going to go a little bit deeper into what is this light test. Basically, the light test is asking whether it produces a yellow pigment after being exposed to light. In the performance of this test, you will have two tubes of the organism. You will have one which is completely wrapped in aluminum foil, and you will have the other one also wrapped in aluminum foil, and both of them will be placed into an incubator. After the organism is starting to grow, you will remove one tube only from the incubator, unwrap the aluminum foil, and expose it to light. After about 8 hours or so of being exposed to light, you then wrap it back up in the aluminum foil and put it back into the incubator. Leave it in the incubator for 24 hours, then bring both tubes out, unwrap them, and compare the color of the pigment. If you have a group 1 photochromogen, as on the upper left-hand side, you will see that after incubation, in the incubator, it will turn yellow after light exposure. The one that was not exposed to light has no color. This is known as a photochromogen. On the bottom of the slide, you will see group 2, or the so-called scotochromogen. These organisms, no matter whether they're exposed to light or no light, they will have a bright yellow color. Group 3 on the upper right-hand side is a non-photochromogen. No matter whether this organism is exposed to light or not, it never produces a pigment. This is a very, very simple test, but the Runyon Classification System based on the light test was used for decades as a starting point for our identifications. So based on this Runyon Classification System, you can see on the next slide, we can group different organisms into Runyon groups. Group 1, the photochromogens, which turn yellow when exposed to light, include the major species kansasi, simii, szulgai, and marinum. Szulgai is one of the most unusual organisms in the light test in that it will actually be a photochromogen when at 25 degrees, and if you notice in group 2, it is actually a scotochromogen when incubated at 37 degrees. When we were using the light test to help us with identifications, this was a very important little fact that we kept in our heads with the identification of szulgai. With group 2, the scotochromogens, the yellow pigment and dark or exposure to light, the very common species of Gordonii is a group 2. Moving on to the next slide, the group 3 non-photochromogens include the very important species avium-intracellulare and Haemophilum. The group 4 organisms are the rapid growers. These grow in less than 7 days and include over 20 species, with the most common 4 listed on this slide: a Fortuitum group, Abscessus, Schelonii, and Mucogenicum. On the next slide are the ones which are mostly reported as to cause disease. Of course, the major pathogen of our genus Mycobacteria is tuberculosis, but you can see on this slide there are many species of Mycobacteria capable of producing disease. On the next slide, you can see that ones that rarely, if ever, cause disease. If so, it is most likely in an immune-compromised host. We're going to now start talking about specimen collection when dealing with mycobacterial disease. The sputum specimens are, of course, the most common ones used in the diagnosis of tuberculosis. Classically, 3 specimens have been collected 24 hours apart. It's the so-called early morning sputums. But since regulations have changed recently, we are in a movement, of course, to try to release patients more quickly from isolation and more quickly from the hospital, that now most states and regulatory agencies say that you can collect sputums 8 hours apart, but they must be at least 8 hours apart and submitted to microbiology for testing. You can also see on this page that there are many specimens that can also be collected, such as bronchial lavage fluid, tissues or wounds, CSF, urine, stool, gastrics, and blood. If you are collecting urine, you normally do 3 to 5 early morning collections. Urine is a controversial specimen that is collected because it can be contaminated from environmental sources. Stool is usually to look for M. avium complex. Gastrics are often done on children that are incapable of producing sputum specimens. The one thing that you have to remember about gastrics is they can be extremely acidic, and so you need to adjust the pH when they arrive in the laboratory so the AFB will survive. Blood can be collected when you're suspecting disseminated infection and is often used and tested in automated systems. On the next slide, we'll talk about the safety precautions that we need in the AFB laboratory. If you are a full processing AFB laboratory doing specimen processing, identification methods, and also doing susceptibility testing, you need to do what are called Level 3 safety precautions. This includes having a Level 2 HEPA filter approved biosafety cabinet with the return air vented to the outside of the laboratory. You can see in this picture on the upper right hand side the stovepipe looking apparatus extending up from the biosafety cabinet. Also, safety cabinets must be certified at least yearly for safe use. Oftentimes, people working in AFB laboratories will have them certified every 6 months to make sure that the HEPA filters are cleansing the air properly. You must also have negative airflow in the AFB laboratory, an anti-room for dressing and changing and washing hands. And while working in the laboratory, you must wear either a 95 respirator mask or what's called a PAPR, a powered air purifying respiratory mask, which is pictured on the right-hand side of this photograph. You can also, of course, must wear gloves. Disposable gowns must also be worn. In case there is a spill onto your gown, you must be able to remove it quickly and put it into a biohazardous container. Plastic cups also must be used with protected lids for centrifugation of your specimens. On the next slide, we'll talk about how we go about doing specimen processing, start to finish. You can see the conical falcon tube on the upper right-hand side of this picture. You put at least 5 mils of specimen into this conical tube. And then you have to go through what's called decontamination and liquefaction of your specimen. You decontaminate and liquefy a sputum specimen for 15 minutes. To do this, you add 5 mils of 4% NaOH. This will increase the pH of the specimen to 9. This will kill any contaminating bacteria that might be in the sputum specimen. The NaOH also contains N-acetyl L-cysteine solution, and this will break up the mucus in the sputum specimen, releasing any of the trapped AFB. Once the 15 minutes have passed, you fill the tube with a phosphate buffer to neutralize the pH. You then place the falcon tube in a centrifugation cup with a lid on it to protect the tube from breakage. You centrifuge for 30 minutes in your high-speed centrifuge. Centrifugation is usually done at 3,000 times G because you want to adequately pellet the specimen. The mycobacteria are lipid-laden organisms, and you need this fast speed of centrifugation to make sure that you pellet the organisms into the pellet and it does not remain in the supernatant. Following the centrifugation, you pour off the supernatant and prepare the slides from the pellet for AFB staining. Then you dilute the pellet with a small amount of sterile saline for culture. You incubate the cultures at 37 degrees at 5 to 10% CO2 for 6 to 8 weeks. How and why do you perform specimen decontamination? Well, the mycobacteria are more resistant to killing by acids and alkaline solutions than most bacteria, due to the high amount of lipid in the cell wall. This is used to rid the specimen of contaminating bacteria and yeast. For the slow-growing mycobacteria to be cultured, you have to eliminate this contaminating bacteria because they grow 24 times faster than do the mycobacteria. And you have to release the AFB from the mucus plugs in the sputum, or you could miss some of or most of your AFB in the specimen. And all of this is accomplished by exposing the sputum to alkaline acid solutions and mucolytic agents, such as the 4% NaOH and L-acetyl-L-cysteine. On the next slide, you will see the decontamination and digestion process outlined. 4% NaOH is most used for decontamination, and the N-acetyl-L-cysteine is most used for liquefaction of the mucus. The timing is critical and is 15 minutes. Sometimes in special circumstances, you might have a cystic fibrosis patient or a patient that you know might be colonized with mucoid strains of Pseudomonas aeruginosa. In these cases, you might want to use oxalic acid. It is used routinely in these types of specimens. It is a more harsh decontamination, but is capable of killing the Pseudomonas aeruginosa, and so it will not decrease your isolation of AFB by having Pseudomonas overgrowth. You have to, once again, with the oxalic acid, make sure that your timing is 15 minutes. If you over-decontaminate the specimen, you can certainly kill the AFB. As I said before on the next slide, we talk again about specimen centrifugation. The 3000 times G is quite fast and very important. As I said, the AFB are full of lipid. If you do not centrifuge this rapidly, and the AFB is not pelleted to the bottom of the tube, you could pour it off during your supernatant pour-off, and it will also decrease the sensitivity of your AFB stain. So you use this pellet for all of your important testing. So it's very important that you centrifuge rapidly enough to get a good pellet. On the next slide, we're going to start talking about the plating media. There's two types of media that are usually used in an AFB laboratory, and we use a variety of plated and tubed culture media of these two types. The first one is the Middlebrook series of media. These are synthetic media. They're clear media, and they come in both plate and liquid forms. They're called synthetic because we know the chemical ingredients, and there's many ingredients added to get optimal growth for the mycobacteria. These media can be autoclaved, and they're used for culture and for susceptibility testing. The older and very reliable method that's been used for decades is the Lowenstein-Jensen series. This is the green media shown in the bottom right hand of this slide. It is an egg-based media. It is green due to the addition of malachite green, and it's really the only media that we have in all of microbiology which has this kind of unusual greenish yellow color. It is composed of hen's eggs, glycerol, and potato flour. And because it is egg, if you were to autoclave this media, you would actually get scrambled eggs. So the way this media is sterilized is by inspisation, which is a drying process. Because it is dried in this fashion and cannot be strictly sterilized, you do not usually add a lot of ingredients or any antibiotics to the Lowenstein-Jensen series. When you culture your specimens onto the solid media, you incubate at 37 degrees centigrade at 5 to 10% CO2 for up to 8 weeks. On the next slide, though, we will talk about automated detection of the AFB. Most laboratories have moved into automated testing for the mycobacteria because it speeds up detection over the growth on solid media. The two instruments most used for automated detection is the BACTEC Midget 960 and the BACT-Alert. They use liquid Middlebrook 7H9 series media that are in tubes. Both systems have virtually the same detection method. As the AFB can grow in the Middlebrook 7H9 media, the AFB will respire CO2 and the oxygen is decreased. The lower the level of oxygen drops in these tubes, it will cause the fluorescent indicator at the bottom of the tube, as the red arrow shows you in this slide, and it indicates that there is growth in the tube if the tube is fluorescing. These tubes can also be read in the automated instruments, making it more rapid and not dependent upon the human eye to read for fluorescence. Incubation can actually be decreased when you use these automated systems, and you only need to hold your cultures for 6 weeks. Also, since you're using an automated detection method, you usually have more rapid growth in these systems than you would see on solid agar. There is also an automated test that you can use in the BACTEC Midget 960 that can help you identify Mycobacterium tuberculosis. This is called the NAP test, N-A-P, which stands for that very long biochemical, which is, I will attempt to say for you, which is p-nitro-A-acetylamino beta-hydroxypropophenone. And this is a biochemical test which can detect within 5 days if the organism is TB or not. TB will not grow in the NAP test, where your other Mycobacteria species will. On the next slide, we talk about the acid-fast staining for the Mycobacteria. There's 2 primary types of stains used for the Mycobacteria: Carbol Fuchsin-based stains and fluorochrome-based stains. Carbol Fuchsin-based stains stain the AFB red. Carbol Fuchsin is the red-colored stain. Potassium permanganate is the background counter stain, which is blue. The Carbol Fuchsin-based stain is shown in the left-hand picture. There's 2 primary Carbol Fuchsin-based stains, the Ziehl-Neelsen and the Kenyon. The Ziehl-Neelsen uses heat to drive stain into the AFB, where the Kenyon stain uses phenol to drive stain into the organism. And that is the primary difference between the 2 stains. Most laboratories actually use the Kenyon. When you have the Kenyon stain on the microscope, it is read on a light microscope and is supposed to be read on an oil objective for up to 5 minutes. The fluorochrome-based stains are usually aramine-rhodamine-based. They're fluorescent. The organisms stain a fluorescent gold color, and they can be read at either 25x or 40x. Usually they're read for 2 minutes on a fluorescence microscope. Most people would generally consider the Ziehl-Neelsen stain to be most people consider the aramine-rhodamine stain to be more sensitive to the Ziehl-Neelsen or Kenyon, primarily because of the autofluorescence and the ability to have its shining light in your eyes rather than a very flat background of blue and red. On the next slide, you can see how the organisms appear in tissue. The organisms primarily are stained with Ziehl-Neelsen in these slides, or a Kenyon type Carbol Fuchsin-based stain. Most of the organisms of the Mycobacteria can be difficult to differentiate on a Ziehl-Neelsen or Kenyon type stain, but for the most part, you can usually tell Mycobacterium avium complex from the TB organisms. If you look on the tissue slide on the left-hand slide, this is a Mycobacterium avium complex. You can see that the organisms are predominantly very short, and also that there's many organisms crowding in the tissue. If you look on the right-hand side, those are the organisms of Mycobacterium tuberculosis. Organisms are long and they can appear as they are sticking together, and that is due to cord factor. And for the most part, the organisms will appear more beaded and longer than those of avium complex. You can also do direct detection of TB from specimens by amplification, and this is discussed on the next slide. There's two primary methods that are available for doing polymerase chain reaction to look for the Mycobacterium tuberculosis complex directly from patient specimens. This is primarily the GenProbe, or recently purchased by Hologic's TMA reaction, and the Cepheid Expert TB rivampin assay. Both of these are FDA cleared. They are only FDA cleared for respiratory specimens and primarily for sputum and induced sputa. You can detect TB complex in the AFB smear positive and negative respiratory specimens using these assays. Also, the Cepheid assay has also an extra target available where it can detect the rivampin resistance associated mutations of the RPO-B gene. Respiratory specimens first must be decontaminated and concentrated prior to using the GenProbe Hologics assay. But the Cepheid Expert method can also be used on non-concentrated sputum, which makes it an extra added good thing in that you can get a specimen directly from a patient and test it the same day using the Cepheid Expert TB rivampin test. They both amplify a 16S RNA gene sequence of TB. The sensitivity is around 90% for the AFB smear positive specimens and 75% for the smear negative specimens. It's very important to remember that these are tests of diagnosis and not cure, and that you can have residual RNA that can be present in these specimens, patient specimens, up to 6 months after a diagnosis of tuberculosis. Of course, these types of tests are extremely useful for the diagnosis of a patient, but that's not all that can be done on a patient. Of course, you must still perform a culture and full susceptibility testing on any patient suspected of having tuberculosis or a mycobacterial infection. So starting on the next slides, we're going to go through different organisms that cause mycobacterial disease. And we're going to start with the major pathogen of this genus, and the next slide you will see is labeled Mycobacterium tuberculosis. The optimum temperature for growing Mycobacterium tuberculosis is 37 degrees, and in most medias it's going to grow in about 12 to 25 days. If you do have a smear positive patient, and you're using automated methods, sometimes it can grow as rapidly as 9 or 10 days. If you see the picture included on this slide, you'll see that the tuberculosis organisms is buff in color, kind of a beigeish brown color, and it is very dry and looks like a head of cauliflower. And that is very distinctive for TB. In the old world of TB, when we did biochemical reactions, there were two very important reactions that we used: the niacin and nitrate test. The niacin test is positive in Mycobacterium tuberculosis. And this is a very interesting test and kind of a tricky little test. This measures for accumulation of niacin after the organism is grown on the egg-containing medium Lowenstein ginseng. You must do this test using Lowenstein ginseng medium because niacin is accumulated from the egg in this medium. If you were to mistakenly do it on Middlebrook agar or another type of agar, it could be falsely negative. The nitrate reduction test is also positive for TB. It reduces nitrate to nitrite. It is very important to confirm that you actually have a TB organism and not Mycobacterium bovis. Mycobacterium bovis is nitrate negative, and so when you are using biochemicals, that could be useful in the differentiation. The other test that you can use that can help you differentiate bovis from TB is growth in T2H, which is a chemical thiophene 2-carboxylic hydrazide. M. bovis does not grow in T2H. TB does. So you can use this test to differentiate the two. Most people have moved past biochemical testing for doing identification. So one of the molecular ways that you can do rapid identification for TB is using the GenProbe AccuProbe DNA RNA hybridization test. This identifies TB complex organisms with excellent accuracy. You could also use MALDI-TOF mass spec or 16S RNA sequencing also to identify TB. It is all dependent upon the capabilities of your own laboratory. On the next slide, you will see a very, very interesting thing that goes on with Mycobacterium tuberculosis, and that's the demonstration of cord factor. Due to the high lipid that's contained in this organism, the organisms stick together. And when you grow this organism in a broth culture, it can form long ropes of organism totally stuck together, as shown in the upper right-hand photograph. This is very distinctive behavior for Mycobacterium tuberculosis, and none of the other Mycobacteria species will look like this. More slides about tuberculosis. The next one is classic presentation. Of course, TB is a slowly progressive pulmonary infection. You can have coughing, weight loss, and low-grade fever. The biopsy of the lung from most, particularly normal hosts, will show caseating granulomas. Organisms seen in a concentrated AFB stain will indicate that the patient is capable of infecting others. So someone with a positive AFB smear directly from sputum should certainly be put in isolation precautions. One important thing, because the AFB smear is such an important indicator for patient being infectious, you should never do an AFB stain on a non-concentrated sputum specimen and report to a physician. There could be confusion, and they do not realize that it is non-concentrated, and it will give you a very, very high percentage of false negative stain results. So laboratories should never do a non-concentrated AFB stain to look for Mycobacterium tuberculosis. TB, of course, is spread by respiratory droplets. So all patients require respiratory isolation precautions that have a positive smear or are thought to be a high risk for Mycobacterium tuberculosis infection. The next slide discusses TB and HIV and AIDS. Worldwide, TB is the most common opportunistic infection affecting HIV-positive individuals. Pulmonary TB is the most usual progression, the most usual presentation, but with progression of HIV and decline of cell-mediated immunity, particularly as the CD4 count drops, there is greater risk of extrapulmonary dissemination. You can also see granulomas possibly without caseation in this patient group. On the next slide is TB as the cause of scrofula. Of course, this can be unilateral lymphadenitis. The nodes will actually drain to the skin surface as shown in the photographs. TB is cause of scrofula, as can be Mycobacterium avium complex. On the next slide is discussed susceptibility testing for TB. There's two primary methods that are used: agar dilution and the Bactec liquid 7H9 medium process. Most individuals and labs have moved away from doing agar dilution and doing the automated test, which is tested on the automated Midget 960 system. Using the Midget liquid 7H9 system, they test the primary drug panel for the 5 primary drugs used to test TB, which include isoniazid, pyrazinamide, rifampin, streptomycin, and ethambutol. Besides doing this type of primary drug testing, sometimes it is very important to have extremely rapid results because you might have a high-risk patient for having a very resistant organism. There's such things called molecular beacon testing, which are using hybridization probes with RT-PCR that can quantify target DNA. These are used for rapid determination of multi-drug resistant TB and can detect INH and rivapid resistance very rapidly. This is used mostly by some of the public health departments to help rapidly spot if we have a multi-drug resistant TB patient. On the next slide, you'll see that most TB isolates are susceptible to the 5 primary TB drugs. But the populations that are more likely to be resistant to one or more drugs include the HIV/AIDS population and certain immigrant populations that are found in the United States. And of course, the definition for multi-drug resistant TB refers to the multi-drug resistant strain being at least resistant to INH and rifampin, which are the 2 most common drugs used for the treatment of TB. They can also be resistant to additional first-line drugs. On the next slide, we will talk about Mycobacterium bovis. M. bovis produces disease in cattle and other animals. It's spread to humans by ingestion of cows or milk. The most common disease have symptoms like that of TB. M. bovis can also cause an unusual infection, which we do see in modern hospitals, and that's of bladder infections in patients that are treated with BCG, used as an immune adjuvant to treat bladder cancer. BCG is actually an attenuated strain of M. bovis, and when used as an adjuvant, it can become active and cause active infection in the bladder. This will be found, of course, by culturing a urine specimen and growing an organism which at first could resemble TB. This is why it is important to always do rule-out tests for bovis when you are dealing with Mycobacterium tuberculosis infections, particularly when they're found in unusual situations such as a urine specimen in a patient receiving adjuvant therapy. If you're concerned whether it is TB or it is M. bovis, you can do the nitrate test as I discussed before, where bovis is nitrate negative and TB is positive. As I discussed prior, M. bovis does not grow in T2H, where TB does grow in this compound. And also, M. bovis does not produce the pyrazinamidase enzyme, where TB does produce this enzyme. So these are all tests that you can use to differentiate the 2 organisms. On the next slide, we'll talk about Mycobacterium ulcerans. This disease, as shown in the picture, produces a painless boil which can turn into an ulcer known as the Barnes-Dale or Buruli ulcer. It can progress into avascular coagulation necrosis. This unusual type of infection is primarily found on the African continent. If we're to do laboratory identification, the optimum temperature is 30 degrees centigrade. And of course, this is 7 degrees cooler than what we normally talk about growing Mycobacteria organisms. It is slow growing and is niacin and nitrate negative. This brings up a very, very important point concerning the culture of mycobacteria from lesions and ulcers or any kind of skin biopsy. When we're dealing with these types of specimens, we have to do both cultures at 30 degrees and 37 degrees. And when you think about it, it kind of makes sense in that these lesions are on the surface of the skin. They're growing at a lower temperature than an infection inside the body. So it kind of makes sense that they might tend to grow better at 30 degrees. On the next slide, also about Mycobacterium ulcerans, we can say that it progresses, as I said, into avascular coagulation necrosis. And we will move on to the next slide and discuss Mycobacterium kansasi. Mycobacterium kansasi is a very, very important organism that can be cultured at 37 degrees in about 10 to 20 days. It's a photochromogen. It turns yellow after light exposure, and you can see on the picture on the right-hand side how very bright yellow in color it is. Biochemically, it's niacin test negative, nitrate positive. It produces tween 80 and 68 degree catalase reaction. One of the most interesting things about this organism is its acid-fast stain. The cells are long and rectangular and beaded, somewhat like TB, but the organism is usually longer than TB organisms and has this very unusual shepherd's crook morphology. There's a picture on the upper right-hand side that shows how this organism can sometimes be long, beaded, and at the end go into a shepherd's crook. The clinical disease can mimic pulmonary TB, but it does not disseminate. It usually stays primarily in the diseased lung. On the next slide, we will discuss Mycobacterium marinum. The optimum temperature for this organism is 30 degrees. This organism also is mostly found on the skin, and that is why its optimum temperature is 30 degrees. The growth is in 5 to 14 days. It's a photochromogen, and the pigment is produced after light exposure. Mycobacterium marinum can be found in both fresh and salt water. It has been found for many years in swimming pools, fish tanks, and water cooling towers. The disease at one time was even known as swimming pool granuloma. I have a picture on the upper right showing a surfer because we've seen infections in surfing injuries. So this organism is very commonly seen in both fresh and salt water. When you see this disease, it is usually a tender red or blue-red subcutaneous nodule as shown on the next slide. And it can occur after trauma to skin, such as scraping your arm against the rocks cleaning out a fish tank. You can start with one primary lesion, of course, as on the left-hand picture, but the lesions can continue to extend up the arm and spread along the lymphatics. Clinically, this infection can also appear like sporotrichosis. But of course, sporotrichosis is a fungal disease, but the lesions can somewhat mimic that. On the next slide, we have Mycobacterium szulgai. This organism grows at 37 degrees in about 12 to 25 days. It has the very unique feature of being a scotochromogen at 37 degrees, which means it has both color at 30 and in the light and in the dark. And it is a photochromogen at 25 degrees, as shown in the pictures on the bottom right-hand side. This is a very unique characteristic for this species and is the only species known to do this. It is niacin negative, nitrate positive, and it's an unusual cause of disease. It causes rare lung infections. Symptoms are similar to those with TB and may be found most often in someone with a diseased lung or immune suppressed. On the next slide, we talk about Mycobacterium xenopi. This organism is very unusual in that its optimum temperature is 42 degrees centigrade. So it's capable of growing in hot water supplies. It grows in about 14 to 28 days. It is a scotochromogen. But the most unique thing about this organism is it forms what's called an egg nest colony on Middlebrook agar. Isn't it amazing? Look at this picture on the right-hand side. And if you can observe it even more closely if you look under a microscope, it literally looks like an egg nest sitting on the colony, on the agar surface, and that is the colony of Mycobacterium xenopi. It's a rare cause of pulmonary infections, but it does cause disease very much like TB. It's mostly in patients with pre-existing lung disease, and it can be seen in patients with HIV and AIDS. The next slide is discussing Mycobacterium avium-intracellulare complex. M. avium-intracellulare are two different species of mycobacteria, but they're so alike biochemically and genetically, it's kind of difficult to distinguish the species. So no one really spends the time to do so, and it's really maintained its notoriety as a complex, and known as MAC often. It causes opportunistic infections and HIV/AIDS, with high organism load being seen in the lung, intestine, liver, and spleen. Due to dissemination, this organism can also be seen in the bone marrow. Organisms can sometimes be variable in size, but routinely they're usually considered to be much smaller than TB, and they do not have cord factor. Positive blood cultures can be common in disseminated infection. You can also get involvement of the GI tract, and this organism can cause diarrhea. Oftentimes it's your first indication that the organism has invaded a person with HIV/AIDS, that they'll have a diarrheal-like disease with abdominal pain. You will see positive AFB smears in the stool. The pathology is usually necrotizing rather than granulomatous inflammation. On the next slide, you can see that there's a Kenyan-stained tissue loaded with AFB. This would be the way Mycobacterium avium complex can present itself in tissue, very packed out in the marrow. On the right-hand side is a slide of an organism from the laboratory. You can see that the organisms are quite small. They don't really appear all that beaded, and they are certainly not cording like happens with the Mycobacterium tuberculosis. On the next slide, we'll go more into the laboratory identification of Mycobacterium avium intracellulare. In the laboratory, it grows at 37 degrees in about 7 to 21 days. It grows more rapidly than does TB. It's a non-photochromogen. The organism's smooth and has very light, kind of buffy, very little bit of a yellow tone to it. This organism's inert in biochemicals. So we're very lucky that we do have molecular identification, MALDI-TOF mass spec, and genetic 16S RNA sequencing to help us with the identification of this organism. On the next slide, we can see the correlation with HIV and the normal host. MAC disease in HIV is usually disseminated in the end stage of AIDS. It's nonspecific low-grade fever, weakness, and weight loss, and is sometimes presents as a fever of unknown origin. As I said before, it can be abdominal pain and or diarrhea with malabsorption. In the normal host, it presents differently. It presents as a pulmonary disease, much like TB. In a marked percentage of cases, there's older women with history of smoking and a diseased lung that have been colonized and infected with M. avium intracellulare. On the next slide, I'm talking about the rapid growing mycobacteria. In the laboratory, you get growth at 37 degrees in less than or equal to 7 days, and this is why it's referred to as a rapid growing organism. Most the species are positive in the aerosulfatase test, and this is a test that can be used to guide you toward the identification of a rapid grower. There are many new species, but the most common species are the Fortuitum group of organisms, which can cause a variety of infections, including skin and surgical wound site infections. M. szulgai, which causes skin infections, mostly in immune-suppressed hosts, and M. abscessus, which is commonly found in lung infections. Biochemicals used to be used to identify these organisms, and if you do nitrate reduction test, the Mycobacterium fortuitum species will be positive in nitrate reduction, and the szulgai and abscessus will be negative. M. fortuitum is also positive in the iron uptake test. Most progressive laboratories are now using either MALDI-TOF mass spec or sequencing to identify the rapid growing mycobacteria. With more than 20 species in this group, it is far more helpful to use MALDI-TOF or sequencing than to depend on biochemical reactions. On the next slide, we discuss some of the miscellaneous species of the mycobacteria, starting with Mycobacterium gordoni. Gordoni is a rare cause of infection. It's a major laboratory water contaminant in cultures and has been referred to as the tap water bacillus. This is one of the prime reasons why we use sterile distilled water in culture workup to prevent contamination in the AFB laboratory. It is a scotochromogen. Mycobacterium tuberculosis has an association with Crohn's disease. It may cause a small subset of Crohn's, but is inconclusive evidence for causation of Crohn's disease. On the next slide, I discuss Mycobacterium haemophilum. Mycobacterium haemophilum requires hemoglobin or hemin for growth in culture, as the name implies. It will therefore not grow on Lowenstein-Jensen or in the Middlebrook series in the automated systems without the addition of hemin supplements. It is interesting that you will have no growth in these different systems, and then you will put these patient specimen on the same media with a hemin source, or put it on chocolate agar, which contains hemin, and you will get growth of the Mycobacterium haemophilum, displaying that its requirement for hemoglobin or hemin. This organism causes painful subcutaneous nodules and ulcers. It's primarily seen in AIDS patients or patients that are immune suppressed. On the next slide is Mycobacterium leprae. Leprosy is also known as Hansen's disease. Leprosy begins with anesthetic skin lesions and peripheral neuropathy with nerve thickening. Normally, it starts on causing numbness in earlobes or in the nose. There are two types of leprosy, lepromatous and tuberculoid. Lepromatous leprosy causes extremely disfiguring lesions with large numbers of AFB in the lesions. It's also been associated with co-infection with strongyloides, which of course is a parasite. Tuberculoid leprosy is less severe with fewer lesions. There's lower numbers of AFB in the lesions. M. leprae will not grow on artificial media. The armadillo is the natural reservoir. Due to our lack of being able to grow M. leprae, we depend on using polymerase chain reaction on tissue for definitive diagnosis. Lepromatous leprosy is shown in the next slide. On the left-hand slide, you can see the disfiguring lesions in the picture of the child, and that the organisms have an unusual formation where they're described as cigar packets of AFB. The organisms actually are fairly long, and they will line up like cigars in a packet. On the right-hand side are the less or more subtle lesions of tuberculoid leprosy, and you can see that there are fewer organisms in the tissue of this type of leprosy. This slide concludes the Mycobacteria lecture. Thank you for listening.